the fourth section we have. And I need not say anything about the dynamic PG. Our Sharanya is there to present the case, and Dr. Leda. Sorry. Sridhara. I think I have not seen, I think, for long duration, but don't worry. We are there to back you here. All the best. Let us enjoy the feast of knowledge. Actually, I heard it is a nutrition program, so we don't know anything. Almost all senior pediatricians may not be knowing, and so you can teach us also. So thank you all. Best of luck. Thank you.
Okay, I request Srilata Madam to take over and start the proceedings. I request Sharanya to share the screen and start the presentation.
Thank you. First of all, let me thank the office bearers of IAP Kottayam for giving me an opportunity to take over this session. These days, we people from Kerala, we feel that we are our health indicators are at par with the most developed countries. And we have a feel that we don't have patients with severe acute malnutrition. Maybe we sometimes miss cases of nutritional edema. And this case would be, I think it would be an eye opener, so that you'll also be, all of you will be once again keen. You'll not overlook a diagnosis of nutritional edema. And I invite Sharanya to start your case presentation. So this is one of the cases we have seen in our wards 2 months back. So we'd like to share this case with all of you. Sharanya, please take over.
Respected teachers, good evening to all. I am presenting the case of Ashmika, 11-month-old girl child coming from Munnar. Informant is mother and history is reliable. Date of admission was 3/5/22. Date of examination 10/5/22. Presenting complaints: recurrent episodes of loose stools, 7 months of duration. Poor activity, poor feeding for 1 month of duration. Decreased urine output and swelling of lower limb for 3 days.
So Sharanya, so child, 11-month-old child coming with loose stools of 7-month duration. What all things you will be considering in such a case? Say 11 months, that is an infant coming with the loose stools of a long duration, 7 months. That is, she says that it is recurrent episodes, whatever it is. Loose stools for 7 months.
If it be considered, initially it can be due to persistent infection due to enteric pathogens, or it can be due to malabsorption due to fat or carbohydrate malabsorption. That can be due to chronic malnutrition. Also due to infection.
The first thing is it could be distinct episodes of infective of diarrhea due to an infectious cause. Then comes malabsorption.
Then dietary protein intolerance.
Okay. Like what?
Milk protein allergy. Cow's milk protein allergy.
Okay. Soya.
Then
egg
can be
protein.
To,
all these can produce intolerance.
Some risk factors like socio-environment and nutritional factors, like improper hygiene, then early and improper complementary feeding.
Okay, those things can lead on to recurrent episodes of infective diarrhea. Then other than that, causes?
Chronic diarrhea causes, it can be intestinal causes like malabsorption, tropical sprue, lactase or isomaltase deficiency. Inflammatory causes like TB, Crohn's disease. Then it can be due to immunodeficiency, like isolated IgA deficiency or combined immunodeficiency. Other endocrine causes like diabetes insipidus.
Diabetes insipidus?
Endocrine diabetes insipidus can present as polyuria, polydipsia with diarrhea.
Yeah, sure. Okay, if you should talk about hyperthyroidism.
hyperthyroidism,
hypoparathyroidism.
hypoparathyroidism.
All this can cause.
Then adrenal insufficiency can also cause chronic
You
pain.
forgot about the cystic fibrosis.
Cystic fibrosis. Then pancreatic enzyme deficiency like lipase, alpha-1 antitrypsin deficiency. In protein losing enteropathy.
Protein losing enteropathies. Any malignancies that can produce diarrhea?
Intestinal lymphoma.
Yeah, lymphoma.
HIV infections itself can cause.
Which all chronic infection can cause diarrhea other than
TB.
recurrent episode?
TB,
Mm.
HIV,
Mm.
Crohn's disease.
Crohn's disease and infective
Comes
cause.
under inflammatory cause.
I'm asking about infective causes.
Madam,
Infective causes.
Behçet's disease.
I'm asking about infective causes, not inflammatory, infective. We talked about tuberculosis like that. Any child with a chronic diarrhea, you have to suspect which condition.
Enteric infection like giardiasis and all.
Okay. HIV infection, you should always rule out in any child with a chronic diarrhea. Okay, as you told, giardiasis is also an infective cause, cryptosporidium. Okay. So you have some diagnosis with you. Either it could be discrete episodes of infective diarrhea due to various environmental factors, socio-environmental factors. Then it could be due to some pathology to the gastrointestinal tract. Okay, so you have some conditions in your mind. Now, a child with a long duration of loose stools, presenting with poor activity and poor feeding, then what will you think at that instance?
Malnutrition itself can cause mental changes that can present as poor activity. Then
Okay, severe form of malnutrition may be the cause for the poor activity and poor feeding.
Severe anemia.
Okay.
If it was an acute presentation, we have to consider for hypoglycemia, electrolyte imbalance.
Okay.
Then
During
infection,
an acute
CNS,
attack. Okay.
CNS infections.
But this persisting for last 1 month. Okay, CNS infections. Okay. Then decreased urine output and swelling of lower limbs. In this scenario, in a child with
nutritional edema.
the first thing we will consider will be
nutritional
edema. Then. Okay. Then
if it was associated with hematuria and acute onset, we have to consider HUS and tubular necrosis.
okay.
Coming to the renal causes.
During an acute attack of diarrhea, if you're having reduced urine output, definitely think of then this renal cause. That is acute tubular necrosis due to severe dehydration causing reduced urine output and edema. In that case, initially it starts in a periorbital facial puffiness, then only it proceeds to swelling of the lower limbs. So also we can think of HUS also, but predominantly a swelling over the lower limbs, we'll think more in terms of a nutritional edema itself. Okay, then proceed with the history.
History of present illness. 11-month-old child who was apparently normal till 4 months of age presented with history of recurrent episodes of loose stools once early complementary feeding was started. Frequency was about 5 to 6 episodes per day, lasting for 3 to 4 days. With monthly
that is each episode used to last for 3-4 days.
3 to 4 days, and monthly she has 1 to 2 such episodes with passage of normal stools in between.
Okay.
The stool was of watery consistency and yellow, non-bulky, non-foul smelling, not suggestive of any fat malabsorption, no blood or mucus in stool, not suggestive of any infection, non-explosive, no perianal excoriation, not related to any particular food item.
So so what sort of a diarrhea do you think this? A small
This is-
bowel diarrhea or a large bowel diarrhea history-wise?
History-wise, it is infective diarrhea, suggestive of infective diarrhea.
How do you differentiate between a small bowel? What are the features of a small bowel diarrhea?
It will not be associated with feed intake and it will be non-bulky, non-explosive, no perianal excoriation. And
Small bowel diarrhea, what will be the volume of the stools in a small bowel?
minimum quantity, minimum amount. It will be
You're telling the opposite thing. That is large bowel diarrhea. What are the features of a large bowel diarrhea? Suppose you are having a child with colitis. What are the
it will be minimal
small amounts?
Small amounts.
Frequent stools with blood and mucus.
Blood and mucus. Short bowel, it will be watery and
small bowel. You mean small bowel?
Small bowel, it will be watery and will be large quantity, large amount.
Large amounts.
And watery consistency.
You should no blood and mucus.
No blood and mucus.
Okay. What about the explosive? You're talking about the explosive stools. Where do you get it?
Lactase deficiency, congenital lactose intolerance.
Only congenital? Acquired you don't
no,
get
acquired also. Lactose intolerance in general.
Okay. So when there is carbohydrate malabsorption, you can get this watery explosive diarrhea. Why is it explosive?
Fat globules will be.
Fat globules produce explosive diarrhea. Anshad, can you give the answer?
Large amount of gas.
Yeah. Hydrogen ഒക്കെ ഉണ്ടാവോ? So what happens when there is carbohydrate malabsorption?
The luminal absorption will be low. Solute absorption will be low. As a result,
what happens to the unabsorbed carbohydrate? It is acted upon by the colonic bacteria.
That produce large amount of gas, anaerobic.
Yeah, it produces hydrogen and the gases. So also organic acids. So these gases that produce this explosive nature. And the unabsorbed increases the osmolarity inside the intestinal lumen, and that produces osmotic diarrhea. So the volume will be high. Okay. So that is why it has large volume stools. It produces explosive nature because of the gases in it. And because of the organic acids, it causes perianal excoriation. Okay. Then non-foul smelling. Okay. Not related to any particular food item. What all food items in particular you ask?
Gluten diet, gluten, cow's milk.
Gluten, in that matter, does it produce immediately after intake of a gluten-containing diet? Can you mention some of the gluten-containing diet? The gluten-containing diet. Common. Wheat. Wheat, barley, മിക്കവാറും എല്ലാ
Wheat.
dietലും. Okay, so do the symptoms appear immediately? Suppose you have some wheat containing diet today, chapati today, and tomorrow the symptoms will be there?
No.
It's not like that. For
Okay, all
celiac
right, no.
disease, it's not like that. Because symptoms appear only later. Okay, it's immunologically mediated. Symptoms appear only later, but it is only after introduction of the gluten-containing diet. Okay, it can appear months or even years after introduction of the diet of gluten-containing diet. So it's not like that for celiac disease. But suppose the patient has a lactose malabsorption, child having, whenever child gets a milk-containing diet, immediate following that, the child be having symptoms. So also is milk protein intolerance. Okay. Okay, then.
Complementary feeding was started at 4 months of age with dilute ragi and cerelac given through bottle.
Is there anything wrong with the starting complementary feeding at 4 months?
No, since the gut maturity and the gut enzymes to digest cereals will be developed by 4 months of age. And also,
so what's the general recommendation? What's the general recommendation?
6 months is the general. 6 months is the general recommendation. But if mother is a
this is to facilitate maximum
breastfeeding.
Okay. But if the mother is going for working work and yes,
it can be started from 4 months of age because the gut gets matured by that time, and also the head holding and loss of jaw thrust and hand mouth. Child will be starting mouth enjoying and hand mouth coordination. So it can be started by 4 months.
Anyway, maybe started. Suppose you feel that inadequate weight gain and mother maybe we in such cases may be started. Okay, but it then what about this through bottle?
No, that is not at all recommended.
Why?
Infection prone for infections and questionable hygiene also will be compromised.
How do you give this the ragi complementary feed? What is the consistency to begin with?
It will be porridge consistency, semi-solid porridge consistency, and that too we can give through cup and spoon.
Okay. Through bottle, it will be like
a liquid form. Liquid.
Okay.
Questionable hygiene in the form, they are using a single bottle for the entire feed and questionable hand hygiene before preparation of feed. They are giving 6 feeds per day, 2 spoons each feed along with DBF. They started as such and continued in the same frequency. There was
from 4th month, all these 7 months, they were giving the same amount. They have not changed to a solid food. They have not.
No, they have not changed also, and they have not increased the frequency also. No.
Regarding that frequency, 6 feeds per day, what is your opinion about that? And from the beginning itself, 6.
No, we have to give only 1 to 2 servings per day. The initial 1 month, 1 to 2 servings per day, and we have to slowly increase by half spoon to half cup. And by 6 to 9 months, we can give 4 to 5 servings because the DBF will be direct breastfeeding will be compromised if we start on with.
If they're giving 6 feeds like this, just watery something, the breastfeeding will be compromised. Okay.
There was associated poor weight gain from 4 months of age. They consulted local hospital
till 4 months. It was normal. They were told that it is normal.
Normal. They first of all seeked only medical advice at the time of 9-month immunization. That time they were informed to have inadequate weight gain, and they were given ORS. Dietary modification was suggested, that they were advised to give a semi-solid consistency food, and the frequency also was suggested by them, but they failed to follow.
Okay, that is immunization at 9th month.
9th month.
Okay, till then they have not sought any medical attention.
No, no.
Okay, that means these episodes were not that severe enough, right?
Yes. Yes.
Okay. But did they
For-
notice that child is not gaining weight adequately?
No,
Even
that
before
also
that?
there was no complaint by the mother. By examination only we found that.
Okay.
Mm.
They never felt that the child is growing well.
Whenever we asked the mother, she was not at all complaining about the poor weight gain. Only after attending the immunization only they felt like the baby was not gaining weight.
Okay, suppose you have a child who is otherwise well, but the mother says that child is passing stool 6 to 8 times. Can it be normal? Suppose the child was gaining weight adequately.
Yes, the gastropolyp reflex can also present as
Yes, yes. During
loose stones.
infancy, the frequency of stools can even be 5 to 6 times. But if the baby is gaining weight adequately, it may be a normal phenomenon. Okay.
For the past 1 month, history of poor activity and poor feeding, mother noticed child was irritable with weak cry, who initially used to creep, now showing poor interest in surroundings, poor interaction with mother, and refusal of feeding with poor activity. Had also associated whitish oral lesion, not associated with fever or incessant cry or seizures or pallor, no associated skin lesions. In the past 1 week, feeding progressively decreased with increased frequency of loose stool, about 6 to 8 per day. Yellow, which was of the same consistency, watery, non-bulky, non-foul smelling, not bloodstains or any association with feed intake. There was associated episodes of vomiting after each feed, which was non-bilious and non-projectile. They managed at home with some home medication. And past 3 days, they noticed reduced urine output and swelling of both lower limbs. Last urine was passed 6 hours prior to admission.
So this time the diarrhea was a severe one.
Yes. For the past 1 week, the amount increased frequency.
The
and
last
also,
episode was a significant one episode. So this time the child had possibly there's a
poor child also had a poor feeding intolerance was increased, and also episodes of vomiting was there in the past 1 week.
only this time the child had vomiting.
Yes, ma'am. Yes.
Okay, possibly because of vomiting, child didn't take anything at all. Okay.
There is no history of fever, no periorbital or facial puffiness or reddish discoloration of urine or crying during micturition, suggestive of any UTI. No sucrose cycle, head sweating or abdominal distension, suggestive of any cardiac illness. No cough or rhinitis or fast breathing, suggestive of any upper respiratory infection or lower respiratory infection. No bony deformity, gum bleeding, skin lesions, hair changes or pallor, suggestive of any micronutrient deficiency. No skin infections or ear discharge, suggestive of any immunodeficiency. No icterus or bleeding manifestation, suggestive of any liver pathology.
Sharanya, you're talking about this for the last 7 months. No fever. No fever.
No fever. No fever.
Okay, suppose there was a on and off fever in a child with a chronic diarrhea. What all conditions you will suspect?
Immunodeficiency, including HIV.
Okay.
Then chronic inflammatory conditions.
Inflammatory bowel disease can produce. Then malignancies also, lymphoma.
Malignancies.
Okay. Then you're talking about the periorbital puffiness. What was in your mind?
Madam, renal disease.
അതായത് ഇപ്പോഴത്തെ റെഡ്യൂസ്ഡ് യൂറിൻ ഔട്ട്പുട്ടിന്റെ കാര്യമാണോ വെച്ചിട്ടാണോ അത് ചോദിച്ചത്?
അതെ.
ഓക്കെ
Past 3 days.
ഓക്കെ What about the success cycle in this context?
We have to rule any cardiac related illness for failure to thrive.
But you
Underlying
already have a child with a recurrent diarrhea. That itself is a cause for poor weight gain and all. Okay. Then cough, rhinitis, fast breathing.
Respiratory infection, and also
Okay.
in
Okay.
Ig deficiency.
Okay, that you should have been more particular. The symptoms suggestive of a frequent lower respiratory infection. In that case, you can think of immunodeficiency conditions as well as cystic fibrosis in this particular context. Most common things I'm mentioning. Okay, about skin infections and ear discharge.
Chronic immunodeficiency only suggested.
As well as cystic fibrosis, not skin infection, about the ear, persistent nasal, actually they produce chronic sinusitis. Okay. Pallor, icterus, bleeding manifestations.
Madam, pallor for chronic infection and poor activity and all, and icterus bleeding manifestation associated liver.
Even a persistent diarrhea, chronic diarrhea itself can produce anemia. Okay. Icterus.
Liver disease.
Okay, they can produce fat malabsorption and recurrent diarrhea. Persistent diarrhea. Okay, then proceed.
Past history, no significant illness in the past, no recurrent infection.
That is in the past means? In the past means prior to the onset of this. That is before 4 months of age. First 4 months, child was absolutely normal. Apparently, otherwise normal. Okay.
Otherwise. Antenatal history, primary mother considered 24 years of age, non-consanguineous marriage. Uneventful antenatal period with a regular antenatal checkup and weight gain of 10 kg. No history of maternal infection or growth restriction or sepsis risk factors. Natal, child born by term, emergency LSCS indication was fetal distress. Child cried soon after birth with a birth weight of 2.5 kg. Uneventful natal and postnatal period. Child was breastfed within 1 hour. No prelactal feed. Child passed urine metformin within 24 hours of life, passing normal yellow stools with 4 to 5 per day and normal consistency. Child was discharged on postnatal day 5.
Okay, suppose this child is developing diarrhea immediately from the newborn period itself, profuse watery diarrhea. What are the conditions you will consider?
Congenital chloride diarrhea.
Chloridoria. Okay, then. Anything else?
Congenital malabsorption syndrome. Congenital
lactase deficiency, congenital lactase deficiency.
Lactase deficiency,
microvillus inclusion disease, all these can produce diarrhea starting from the newborn period itself. And suppose this starts immediately after introducing cereals, sugar, etc.
Sucrose or isomaltase deficiency.
Sucrase isomaltase deficiency. Okay. So that is regarding the time of onset. As far as our patient is concerned, she was normal till first 4 months of age. So, right?
Yes, ma'am. Development history, no delay in attainment of development milestone. Child was standing with support at 10 months, immature pincer at 10 months, bisyllable by 8 months, waving bye-bye by 9 months. After the onset of illness, child now only sits. There is a developmental arrest, like child only sits with support with decreased verbal output.
Crawling and all disappeared.
Yes,
Just sitting.
yes, ma'am. Just
She
sitting with
refused to move
some-
around.
Yes, ma'am.
Okay.
With decreased verbal output and poor interest in surroundings.
Okay.
Dietary and nutritional history. Child was exclusively breastfed up to 4 months. No prelactal feeds. Complementary feeding started 4 months. As
Yes,
mentioned
you have
earlier.
given a
also-
detailed
also
earlier
mentioned.
itself.
Yes.
Okay. Because dietary history is very important when you consider cases with the
Malnutrition.
undernutrition.
Required calories for 720 kilocalorie with a deficit of 450 kilocalorie and 6.4 gram protein. Child is
Okay.
immunized for age till date. No family history of any neonatal
So
death
the
or infant
dietary,
death.
going back to the diet, because that is very important. Well, what are the important striking things here?
One is that the dilution. Then they are giving about the DBF is compromised. They are giving about 6 feeds of ragi and cerelac.
Okay.
And no other food items was introduced at all.
There is no first of no variety, right?
Nowhere.
Okay, it's not even in the proper amounts, proper consistency, and in a okay, in an acceptable way. That is, it is not right in the type of feeds, the amount, and also the number of feeds, right? So most striking is it's very much deficient. How many percent? What's the percentage? When it they require 720 is getting only 450.
Approximately half only. Just more than
Less,
half.
Okay. So very much diminished calorie intake, and this has been there for so many months.
Yes, ma'am.
It's the same feeding pattern for last 7 months.
Yes, ma'am. They have not increased the frequency and also the variety of food.
And also the consistency.
Consistency also.
Okay. Why did they give like this?
Once the mother felt like there is decreased lactation and the family members also persuaded them to start complementary feeding.
Okay, they were never given any advice regarding how to feed the child, feeding advices other than from the family members.
When they came for the immunization,
that is at 9th month. Before that, at 1.5, 2.5, 3.5 months.
No,
they were advised to give. Okay,
only grandmother is staying with them.
Okay. No health worker approached them after that. No. Okay. Yes.
Child is immunized for age till date. No family history of infant death or neonatal death or immunodeficiency. Father is 28-year-old, mother is 24-year-old. Parents are educated up to middle school. 4-membered family, lower middle class according to Kuppuswamy's scale.
Is there any consanguinity? Consanguinity?
Non-consanguineous, madam.
Why? Importance? This in a child with a chronic or recurrent diarrhea. A chronic diarrhea like that. Consanguinity. Suppose this child is also having few admissions or respiratory infections.
Immunodeficiency.
Immunodeficiency. Cystic fibrosis. Cystic fibrosis. Ebola, diarrhea as well as respiratory. ഞാൻ ക്ലൂസ് ഒക്കെ തന്നിട്ട് പറയണം എന്നാല് പറയുന്നു. Okay. So they're educated up to the middle school.
Yes. 4-membered family.
That means 4 members means it's the only child, no?
Including child, one grandmother, father, mother,
Okay.
child, and grandmother.
Extended nuclear family. Okay.
Sanitary latrine present. excreta is disposed in underground. They are saying like that. Drinking water from well, boiled or not.
Underground.
Some underground in the sense they are making a.
They dig up under then.
Like a dig.
Okay.
There. Then drinking water from well, boiled or unboiled, not mentioned.
Okay. Why these things are important?
In chronic malnutrition, socio-environmental factors plays a major role.
Our child is having, what are the complaints of our patient? Main complaint?
Recurrent loose stools?
Diarrhea. Recurrent
yes.
diarrhea.
For the past 7 months.
So do you think that the environmental factors are important in this case?
Yes, ma'am.
Okay, ignorance of the mother?
Yes.
Regarding infant feeding?
Yes.
Then water, drinking water? Safe drinking water, and it's not possibly the water may be contaminated, and they don't use the latrine to disposal of the child's excreta. All these can maybe are contributory in this case. Okay, so the socioeconomic history is also important in any child with the undernutrition as well as again diarrhea. And who is the breadwinner?
Father.
What is he doing?
Unskilled working. Unskilled worker.
Okay.
Staying by Munnar, doing all the unskilled work that he gets on a daily basis.
How much is he paid daily?
Daily total of monthly income is only less than 2,000.
Monthly income less than 2,000.
Properly only around 4,000, 5,000 only total of monthly income.
So this is also important, whether they are able to purchase, and a purchasing capacity is also important. Okay.
To summarize from history, 11-month-old first-order girl child of non-consanguineous marriage, uneventful antenatal, natal, and postnatal period with a birth weight of 2.5 kg, developmentally normal, exclusively breastfed up to 4 months, thriving child with history of early and improper complementary feeding, recurrent diarrhea and poor weight gain, presented with poor activity and poor feeding with decreased urine output and edema. Can be possibly due to a chronic nutritional deficiency, possibly severe acute malnutrition.
Okay.
Coming to the general examination, at admission, child was apathetic, poorly interested in surroundings, moon face and small for age, appeared edematous, moderate pallor, bilateral pitting pedal edema over dosum of food, no icterus, cyanosis, clubbing or lymphadenopathy, vitals, heart rate 120 per minute, respiratory rate 28 per minute, temperature 98 degree Fahrenheit, no hypothermia, CRT less than 2 seconds, saturation maintained in room air. Head to foot examination, head appeared small, shape normal, AF is
but the picture head appears to be large because of, I think it's because of your photo. Okay.
Head circumference is less than hair is lustreless, thin and easily pluckable. Eyes sunken, absent tears, conjunctiva normal, no signs of vitamin A deficiency, no vital spots or cirrhosis. Cheeks were puffy, ears normally set with no discharge, shiny skin, no rashes or any other skin lesion. Oral cavity, oral mucosa was moist with oral thrush and angular stomatitis, no cheilitis or ulcers. Chest normal, no Harrison sulcus or pigeon chest or actic rosary suggestive of vitamin deficiency. Protuberant abdomen with normal skin turgor. Upper limbs appeared wasted with pedal edema. Now showing about the growth chart, weight for age is well less than -3 standard deviation. This shows the trend in the weight gain. Up to 3.5 months of immunization, child was having steady weight gain, and then there is a drastic fall in the weight. Height for age less than -3 standard deviation. Weight for length less than -3 standard deviation. Severe underweight, grade 4 PEM according to IAP. Third degree stunting, severe wasting. Mid-upper arm circumference 11 centimeters, suggestive of severe acute malnutrition. Head circumference less than -3 standard deviation.
Okay. The anthropometry, you have a diagnosis of severe acute malnutrition.
System examination, oral mucosa was moist, oral thrush, as already mentioned. No shifting dullness, no hepatosplenomegaly, bowel sounds were normally heard. All other system examination was normal. Summary, 11-month-old.
So you had dehydration. One is dehydration,
Dehydration, edema,
then apathetic child. Then the child had some dehydration. Well, it's really difficult to assess dehydration in a child with severe malnutrition, but you have found there is dehydration. Then there is edema, nor there is angular stomatitis, right?
Yes, ma'am.
Any skin changes?
No, at the time of examination, no skin changes.
Okay, no skin changes. And then a protuberant abdomen.
No shifting dullness and no hepatosplenomegaly.
Okay. Suppose the child is having hepatomegaly, what all are the possibilities in a child with the severe malnutrition? Especially in the context of recurrent diarrhea.
Malnutrition, like kwashiorkor liver can be enlarged.
Due to?
Kwashiorkor edematous malnutrition.
Due to what?
Hyperalbuminemia. And
that produces hepatomegaly.
Fatty liver.
Fatty liver. Infiltration. Okay. Then other than that, just kwashiorkor can produce hepatomegaly. Anything else?
Malignancy.
No.
Okay. Any? Cystic fibrosis. Okay. Yes.
Summary. 11-month-old first order girl child of non-consanguineous marriage, uneventful antenatal, natal and postnatal period. Developmentally normal, breastfed up to 4 months with early and improper complementary
and developing normally till around 4 months of age.
4 months, early and improper complementary feeding with recurrent diarrhea and poor weight gain, with poor activity, poor feeding, loose stools, with symptoms suggestive of dehydration and edema. Examination showed apathetic child with pedal edema and hair changes with some dehydration. Anthropometry suggestive of severe acute malnutrition. System examination was normal.
So now, what are your thoughts?
My diagnosis will be edematous severe acute malnutrition with some dehydration.
Okay. Anyone? Okay, that is all of us will agree. And most possible causes behind it?
From this history, one is socio-environmental, poor education and all. Then nutritional factors like improper complementary feeding and all.
Okay, so because of improper feeding, which has led to this SAC. Other than important other considerations you have in your mind? because
Infections like bottle feeding, predisposed to infection.
അതെല്ലാം കൂടെ ചേർത്താണ് നമ്മൾ പറയുന്നത്. എല്ലാം കൂടെ ഒരു ന്യൂട്രീഷണൽ, അതായത് what they have been provided, the nutrition they have, the parent is offering, caregiver is giving, that was inadequate. That is an exogenous cause. Any other endogenous cause you will consider, because you, or it is only that you will consider. You want to rule out some conditions even at the first instance. Or will you evaluate for some other conditions also? Or you straight away start managing accordingly?
Chronic diarrhea evaluation should be done.
Okay, we'll proceed.
For this child, basic investigations to be done are
Basic investigation. What do you mean by basic investigation?
Madam, okay. Madam, first is I will do a complete blood count. First, I will look for sugar value, sugars, complete blood count.
You
Then
have to rule out hypoglycemia.
hypoglycemia. Then we have to look for inflammatory markers to rule out any infection. Then electrolytes, RFT, LFT to rule out
Infection. You have to screen for infection.
CRP. Then
why RFT important in this particular case?
a renal cause to rule out the acute child present with itself decreased urine output.
Reduced urine output and edema. Okay, definitely it should be.
Electrolytes.
Yes.
Then LFT to look for protein and albumin, total protein and albumin. Then urine routine, stool routine, cultures, blood culture and urine culture. Then smear.
Cultures.
Then
Because
we have to rule out.
These are things you have to do for any child with with complications.
Okay. To rule out any infection, TB, tuberculosis should be ruled out. We'll do Manto test and chest X-ray. Then HIV.
HIV should be done. Any child with chronic diarrhea, you have to do evaluate for HIV also.
Then I will proceed with the management.
You'll check anything in the mother?
Madam, sir?
Have you checked the mother properly?
Yes, sir. Mother is, she had a adequate weight gain, but mother is only 48 kg with pallor.
Father also, actually, when a malnutrition sugar comes, you along with when you are advising, I think you have to check the
caregiver.
Yeah.
Caregiver.
Care. That's most important. One of the most important.
Okay, sir.
Because we have, you say that they have only 4,000 rupees for.
That is also wrong.
I
I don't know how she calculated. I'm sorry.
They due to COVID, they were saying due to COVID, they were getting only one day job from Munnar.
The people cannot sustain with the 5,000 rupees.
And these days,
So, I know, forget this time, you know, that's something.
And also health of the parents in that aspect, as well as another thing, HIV. Because,
Yeah, that's one.
Family history. Family history, you should ask about the health of both parents. Are they healthy or are they getting recurrent health problems? That you have to inquire. And also the job also. Certain jobs we give no chance of having HIV. What are those jobs?
Madam, I didn't hear.
ഏതൊക്കെ ജോലിയുള്ളവർക്കാണ് സാധ്യത കൂടുതൽ എന്നുള്ളത് HIV?
Poor socio-environmental background.
ഈ കൊച്ചുതുണ്ട്
അവർക്കാണ് HIV ഇൻഫെക്ഷൻ കൂടാൻ സാധ്യത. വളരെ ചില ജോബ്സിനാണെങ്കിൽ കൂടുതൽ സാധ്യതയാണ്.
ട്രക്ക് ഡ്രൈവർ,
Drivers.
ട്രക്ക് ഡ്രൈവേഴ്സ്, അതായത് ലോങ് ഡിസ്റ്റൻസ് വണ്ടി ഓടിച്ചു പോകുന്നവര് ഉള്ളവർക്ക് കൂടുതൽ ഒരു സാധ്യത ഉള്ളത്. ഓൾസോ അവരുടെ ഹെൽത്ത് തീർച്ചയായിട്ടും മെൻഷൻ you forgot to mention. Okay. And that important point is their health also. Healthy. അപ്പൊ എപ്പോഴും അമ്മ എങ്ങനെ എന്നുള്ളത് പ്രത്യേകം ശ്രദ്ധിക്കേണ്ടതാണ്. ഓക്കെ, പറഞ്ഞു. സ്റ്റൂൾ എക്സാമിനേഷൻ നമുക്ക് എന്തൊക്കെയാ പറഞ്ഞത്? കാരണം ഈ കേസിൽ സ്റ്റൂൾ എക്സാമിനേഷൻ റുട്ടീൻ എക്സാമിനേഷൻ വെറുതെ പറഞ്ഞു പോയാൽ പറ്റൂല. ബിക്കോസ് most important thing is regarding the loose stools. അല്ലെ, കുട്ടിയുടെ വലിയൊരു പ്രശ്നമാണ് loose stools. That case about what all specifically you look in stool examination?
Stool pH.
Because
stool.
you told you had some diagnosis in your mind, other
Yes,
than this recurrent infections.
Stool pH, stool reducing substances.
Stool pH. Stool pH വ്യത്യാസപ്പെടുന്ന എപ്പോഴാണ്?
Madam, in lactose intolerance, less than 5.5, pH will be less than 5.5 with high reducing substance.
Less than 5.5. Okay. Can you give
Then
the condition where? പിന്നെ വേറെ? So when there is carbohydrate malabsorption, you can get a low pH. You were talking about sucrase deficiency. Sucrase deficiency ആണ് reducing sugar ചെയ്യുമ്പോൾ എന്താ ശ്രദ്ധിക്കേണ്ടത്?
കാണത്തില്ല.
pH ന്റെ കൂടെ നമ്മൾ നോക്കുന്ന വേറൊരു കാര്യമാണ് reducing sugars അല്ലേ? reducing sugar എങ്ങനെയാ വരുന്നത് സ്റ്റൂളില്?
Improper absorption due to the enzyme deficiency. There will be decreased absorption of that carbohydrate and sugars.
Okay, if it is a lactose or sucrose. Sucrose reducing alla. It's not reducing, but glucose reducing sugars ആണ്. അപ്പോൾ unabsorbed ആയിട്ടുള്ള ഷുഗേഴ്സ് ആണ് നമുക്ക് സ്റ്റൂൾ reducing sugar positivity കിട്ടുന്നത് നമ്മുടെ ഫെനഡിക് സെർച്ച് ചെയ്യുമ്പോൾ. Sucrose ആണെങ്കിൽ it's not a reducing substance. So you have to hydrolyze it. അപ്പോൾ അതുകൊണ്ട് treat with N/10 hydrochloric acid when you do the reducing sugar examination. Then pH indicates
Acido organic acid.
Organic acids. Unabsorbed ആയിട്ടുള്ള ഷുഗേഴ്സ് ഒന്നിൽ അതുപോലെ തന്നെ കുറെ പാസ് ചെയ്യും, കുറെ ഒക്കെ ആണെങ്കിൽ it's converted to organic acids. That gives the low acidic pH to the sugar, to the stools.
Then stool microscopy.
Microscopy വെറുതെ ചെയ്ത് വിട്ടാൽ മതിയോ?
Ova, any parasite infections.
ഏതൊക്കെ പാരസൈറ്റ് കാണും? chronic diarrhea,
Giardiasis.
giardia, trophocytes with amoeba. പിന്നെ സ്പെഷ്യൽ സ്റ്റെയിൻസ് ഒക്കെ യൂസ് ചെയ്ത് വേണം നമ്മൾ ക്രിപ്റ്റോസ്പോറിഡിയം എക്സോസ്പോറ ഒക്കെ കാണും. You have to specifically ask them to do specific stains for these parasites. Specific ആയിട്ട് നമ്മൾ ചോദിക്കണം, അല്ലാതെ റുട്ടീൻ മൈക്രോസ്കോപ്പി ചെയ്താൽ you won't get it. Anything else in the story you look for in a child with a persistent diarrhea or a recurrent diarrhea or a chronic diarrhea that matter?
Occult blood.
Occult blood, definitely. Very good. Occult blood. Which all conditions you get occult blood?
Cow's milk
Fermentation.
protein.
Cow's milk.
Colitis, inflammatory bowel disease, അതിനകത്തൊക്കെ you'll get occult blood. ഇപ്പൊ ഇത്രയും കാര്യങ്ങൾ സ്റ്റൂൾസ് മിനിമം ചെയ്യുക എന്നുള്ളതാണ്. പിന്നെ ഡിപ്പെൻഡിങ് upon the situation, these are the basic things you have to do in this case, this particular case, and you try management the usual way and nutritional management, and still the patient is not improving, then you have to go for further evaluation of a child with chronic diarrhea, like biopsy, scopies and all, rectosis, moldoscopies, biopsy, all these investigation, more investigation, that is there in imaging, all those things to go if the patient is not responding in the initial 7 to 10 days or so. Then you go for further evaluation of the diarrhea. These basic things you have to do regarding the stool examination. Then the other examination, in this case, preliminary evaluation. You told about sugars, electrolytes, RFT, all those things that you mentioned initially. Apart from that, complete blood count. We didn't mention about that. Complete blood count. How does it help you in this particular case?
Madam, one is for infections.
HP it's
HP, Madam, if HB is, we will in malnutrition, there is no need for correction of anemia in the first stage itself.
Oh, you do a CBC, you look for anemia because you told the poor activity, all those things, lack of interest could be due to iron deficiency. Yeah. Iron deficiency is one manifestation of anemia. So anemia, and also you have a patient who is having recurrent diarrhea. So he's all the most vulnerable for anemia. Apart from that, he's a child who's getting very diet, very insufficient diet. So all these, considering all these things, this child is likely to have anemia. So you should have an assessment of the degree of anemia the child is having. And depending on that, you have to give the management also will change. Right? Then CBC. What are the total count, differential count? Indicator of infection.
Leukocytosis with predominant polymorph with
Elevated ESR.
elevated ESR and CRP, and platelet will be also, if there is a associated infection, thrombocytosis can be present.
Okay. So that may be indicator of sepsis. Or a urinary tract infection, that matter, because UTI can also present with diarrhea. Okay. And so also inflammatory bowel disease. IBDs also you can have inflammatory markers elevated. Polymorphonuclear leukocytosis, thrombocytosis, elevated CRP, elevated ESR, all these things you can get in IBD also. Then peripheral smear.
To look for the more anemia, Anemia, sepsis.
Anemia, either iron deficiency anemia or microcytic hypochromic anemia or dimorphic anemia. And iron deficiency anemia in which particular condition? Celiac disease. At the beginning, you were talking about celiac. Then you forgot about it. So there also you can get iron deficiency anemia. Celiac disease can even present with iron deficiency anemia alone. So iron deficiency anemia, peripheral. Then one condition, acanthocytosis, acanthocytes, peripheral. Which condition? Where you get diarrhea, chronic diarrhea.
A beta lipoproteinemia.
Acrodermatitis.
A-beta lipoproteinemia.
Acrodermatitis.
Sir, പറഞ്ഞ അതിനെ കുറിച്ച് പറഞ്ഞതേ ഇല്ലായിരുന്നല്ലോ ശരണ്യ.
Zinc deficiency ഭയങ്കര important.
You told about mucosal lesions, but no skin lesions. Skin lesions with the chronic diarrhea, it is acrodermatitis. Okay. Okay. So how will you manage?
First, since the sugars are maintained and child is having some dehydration, I will start off with dehydration correction with Risomol at 5 ml per kg every 30. Child is conscious, we can give orally or with NG tube 5 ml per kg initially for 2 hours and later slow correction in 10 hours 5 to 10 ml per kg.
So you have to, in cases of severe acute malnutrition, correction of dehydration is a very difficult thing. We should be very cautious. This is a little bit different from that dehydration correction in a well-nourished child. Why is it so?
Because we should not, it itself is a fluid retention state. We should not overhydrate and underhydrate. And also there is a high sodium and low potassium in malnutrition cases.
Why is it so? We shouldn't have a high sodium and a low body potassium.
Due to reductive adaptation in
reductive. What do you mean by reductive adaptation?
In such cases, since there is malnutrition deficiency, there will be decreased basal metabolic rate. As a result, there will be decreased basal metabolic rate and due to hypoalbuminemia also there will be.
I was asking you about the sodium and potassium. The sodium potassium ATPase. It's an energy.
The sodium potassium pump is less fun due to malnutrition.
Lack of energy. Because it's an energy dependent pump. It is not functioning well. So sodium, which is mainly an extracellular cation, is being pushed in and others pushed out. Okay, so extracellular, there is potassium is being pushed out from the
depleted.
That is being excreted in the urine. At the same time, although sodium is inside the cell. So the total body sodium is increasing. So this is a case. The child is should not be overhydrated. At the same time, you have to correct the dehydration. So it's a very delicate situation. You should be very cautious in correcting the dehydration of these children. So the fluid you give to correct the dehydration should have lesser sodium than that you give for a normal child. That is why you go for a Risomat. It contains almost only half of the
half of the
concentration of
sodium and
sodium
double of the
that
potassium.
you have in a usual dehydration solution, ORS. And you have more of potassium in it.
Potassium.
So that is one thing. That the agent you use for correction of the dehydration in say the SAM children is different, and also the time duration you take is also different. You have to take a longer time, and as far as possible, unless the child is in shock, always go for a oral correction of dehydration. Put in an NG tube. The child is not taking the fluid. You put in a nasogastric tube and give the fluid. Okay. And then you go for the usual 2 stages.
Yes,
management.
usual infections, management of infections.
You want to start antibiotics for this child when he is coming child with SAM is coming with diarrhea and dehydration?
Yes, ma'am. Yes, we
Yes,
have to start
definitely
on
you
with
should start
antibiotics.
with antibiotics.
Ampicillin and gentamicin.
Usually if you got ampicillin.
Then we have to start off with the feeding with F75. Once the dehydration gets corrected, we have to start on with the feeding without skipping off any night feeds. Every 2 hourly feed with cautious feeding starting with F75 and later on with catch-up feeding with F100 once the child is tolerating.
Okay. So what happened to this child?
Initially, the dehydration was corrected within 1 day, and later we started off with the cautious feeding and supplemented antibiotics and other micronutrient supplementation. In the course, in the
Especially
initial
you
days,
have to give zinc.
zinc also, zinc,
and vitamin A.
zinc,
Vitamin A.
magnesium, folic acid. Initially, about on the day 5, child developed skin lesions suggestive of nutritional dermatosis, and later on we started off with RT feeds, and by around 10 days, child started gaining weight, and once attained of about 5.5 kg, child was discharged after giving proper follow-up advices and feeding advices.
Okay. Sushma madam, your reflections. Sushma madam is there. Purushothaman sir.
സുഷമ മാഡം ഉണ്ടായിരുന്നു സിലിത ഞാൻ കുറച്ച് കേട്ടിട്ടുണ്ടായിരുന്നു ഞാൻ മാഡത്തിന് ശബ്ദം കേട്ടു പിന്നെ ഇല്ല അല്ലേ
സുഷമ മാഡം
ഉണ്ടായിരുന്നു മാഡം ലീവ് ചെയ്തിരുന്നു that is a right choice. First comment is because 25th onwards you are going to have ORS week, and so 21st we are conducting a case with the diarrhea. So both of you did the right choice, and the discussion also was excellent. About this case, it's a 99% most probably this is a improper weaning, timing, and the method leading on to persistent diarrhea and this malnutrition. 99%. But when we present, the remote possibility of other entities also need to be considered, and we discussed and included in the last moment. Joseph sir point out that acrodermatitis enteropathica, and you consider the rare possibilities also. There can be a possibility of some other disorders, maybe 1% only. So interesting thing is
when the is persisting for beyond 7 to 10 days of our disordered management.
When this onset of the illness is somewhere around 4 months. That's an interesting, important thing. So that excludes, that helps to exclude many of the problems. Metabolic problems also goes down in the list, but acrodermatitis, enteropathic and all sometimes present start from there onwards. So from that point, when it is onset, there are two ways you need to consider. One is some of the illnesses starting somewhere at that point. Example, immunodeficiency, humoral type, cell-mediated, and other things are all will be starting from the in the first newborn period and up to 6 months. The humoral type of the immunodeficiency starts somewhere there onwards. That is one possibility. The second one is related to the diet. Diet, again, improper methods producing repeated infections. Second is the content. We considered the possibility of the content problem like the celiac disease due to wheat gluten introduction, or the other sensitivity to many other introducing items produced. So in this case, very interestingly, there are episodes between normal period between. That's an important point. And there you need to ask about a little bit details about what are the contents, which are the contents usually the soya protein intolerance sometimes, the wheat introduction and the gluten definitely is there, and nuts, groundnuts, cow's milk, a lot of protein intolerance, and which of these items are included and what brings this thing. So you need to differentiate, is it an infection introduction or an item introduced responsible for this thing? And
here the thing is over the 7 months, it's the same pattern. It's
throughout.
Raggy Cerlac, nothing beyond that.
One very interesting, very important point in the examination part, the head circumference seems to be measured 40. You need to remeasure the head circumference because in this case, you don't expect the head circumference to be 14, 11-month-old. So a bit unusual because by definition also it's more than 3 standard deviations and you will be caught the other things are all very classical, but why should there be a low head circumference? That need to be answered. In that situation, we need to consider.
That much small, sir.
Maybe measurement is wrong. That's what I feel. She measured it wrongly. Maybe it's
also in the
a little.
picture also it doesn't appear that.
Yeah, that's right. Yeah. The picture looks the head almost appropriate. When another point is you should be checking two things: the anus, the angry anus, and stool macroscopy. You mentioned many of the stool investigations and all, but the stool macroscopy for bubbles, the lactose intolerance, the stool will be having gas, bubbly stools, and the anus to be looked for. Both are suggestive of a lactose intolerance. And remote, the other investigations also sometimes.
Microscopy also, fat globules.
Yes, fat, the frotting type of this thing. That is other DDs you already be included the malabsorption states, inflammatory bowel disorders, and celiac disease and all. So there the fatty, greasy, frotting stools is one. Another is a rare possibility of the elastin and the calprotectin and all. It can be included in the discussion only, for theoretical only. So anyway, that is well discussed, the good choice of the case, and congratulate the IAP Kottayam team and Dr. Sridhar and Saranya also. Thank you.
Shanavas sir, are you there? Shanavas sir? Shanavas sir?
Okay. So I am here. So I listened to the discussion. So it was a very good discussion, and also the follow-up comment is also very interesting. As usual, Purushottam sir has concluded the session very effectively. So I think I don't have much to add. So Kottayam IAP Kottayam is regularly doing the PG program. I congratulate Dr. Suresh Vadakkeram, IAP sir, then our secretary and president for conducting this as effectively. Thank you.
Darling madam.
Nothing to add.
Everything is
It
included.
was, everything was very well
Complete.
discussed actually. Yeah. This was to be discussed in our NutriCon actually.
Yeah.
We couldn't do that due to lack of time.
I thank Purushottam sir for being with us during this entire session.
Thank you,
I was
Suresh.
keenly
so relieved
listening to the
seeing
discussion. Keenly listening and responding.
Thank you, sir. Thank you so much, sir.
Oh,
Actually, I was so
thank
much
you.
relieved seeing you.
ഇപ്പൊ തന്നെയുണ്ട് സുരേഷ് പണി ഇപ്പൊ അറ്റൻഡ് ചെയ്യലും കേൾക്കലും പഠിക്കലും ഒക്കെ തന്നെയാണ് ഇപ്പൊ പണി.
Say medical, say nutrition is also easily, even though you say it's a difficult subject to discuss. I still remember ST Ajar telling, and I was only seeing marasmus, Koshoker, marasmus, these are only three definitions. Now the things are changed. But one question I am asking, why we have started antibiotic in the child?
Sir, in childhood,
Because the culture native, urine culture native, every culture native. So is it in? I don't know. Because I'm.
Sir, that is like Charanya, can you give the answer?
Let her, madam. I'm asking her.
So the investigations showed suggestive of infection. The CRP was on a higher side with raised total count. And in the background of this poor...
Even without that, will you start? Even without these reports coming, will you start? Because you have to start immediately.
Yes, in the background of malnutrition, there is always a chance for infection.
This is a severe acute malnutrition child with, and also with edematous SAM. Child coming with diarrhea and dehydration. So what are the indications for starting antibiotics in a child with diarrhea?
One is suspected immunodeficiency.
No, simple.
This is the first reason. Indications for starting antibiotics in diarrhea.
In a child with diarrhea.
Yeah. For everybody, I'm asking. Yeah, she has presented nicely. But just asking a question.
Anybody else that is Sharanya's
Encourage, support.
Indications for starting antibiotics.
Vishnu Rahul, anybody can answer. Vishnu Rahul.
Sharanya for almost
exhausted.
Anybody? Vishnu or Priya?
Vishnu and Rahul is there.
Vishnu, paranyo. Vishnu?
Vishnu, Riya.
Hello.
Paranyo, kelka.
Hello.
Kelka.
Hello, madam. Dysentery.
Okay.
Dysentery, then cholera. Hello. Dysentery, cholera, then suspecting sepsis. In chronic conditions like immunodeficiency, children with severe acute malnutrition may be started on antibiotics.
An indication. Child with diarrhea and severe acute malnutrition is an indication for antibiotics. So also regarding the age,
less than 3 months may be started on antibiotics.
Younger child, because in these situations there is a bacterial translocation is high, the chances are high, and also sepsis presenting as diarrhea, chances of a sepsis presenting as diarrhea is also very high. So in these situations, you start with an antibiotic at the beginning itself. Starting, you have to give at the beginning. So is it clear? Is that point clear, sir? Thank you. Shall we conclude? Sir?
Laila madam is there. Laila madam. Laila Chaka madam. ഉണ്ടായിരുന്നു.
മാഡം ലീവ് ചെയ്തെന്ന് തോന്നേ. അല്ല ഉണ്ട് മാഡം ഉണ്ടല്ലോ.
ലൈല മാഡം are you there?
മാഡം ഉണ്ട്. മാഡം മ്യൂട്ടഡ് ആണ്.
കാണുന്നത് കേട്ടോ. മാഡം മ്യൂട്ടഡ് ആണ്.
മാഡം മ്യൂട്ടഡ് ആണ്. മാഡം അൺമ്യൂട്ട് ചെയ്യണേ. Yes.
Only by 7:30 I could join, even though I wanted to join by 7 itself. I had a guest. In between, I came and listened to you. Pilada's discussion was very nice. PG Saranya also presented well as much as I could hear. The only thing being the topic was malnutrition, I wanted to hear from the beginning till the end, but I could not. Okay, it was nice.
YouTube recording is there. I will post it to the site.
Okay, very well. Very good. Thank you. The post is on the very.
ഒത്തിരി കാലം കൂടിയാ കാണുന്നത്. Nice seeing you after a long time.
In between I see all this, but continuous ആയിട്ട് പലപ്പോഴും പറ്റാറില്ല. അങ്ങനെ.
Thank you, madam, for joining.
Thank you for having called me. Okay. All the best. And others.
Conclude ചെയ്യാം. Okay, over to Dr. Preja.
Thank you, sir. I thank Srinagar Madam, our Associate Professor, Kottayam ICH, for taking that excellent case and for being the expert faculty for today's session. And we missed actually the session in Technical, but it's good we could get this online and it will go for a YouTube recording. So I think majority will get an opportunity to see a very important case for PGs, and I think it's if such a case is there, it's a short case for postgraduates for exam. And thank you, madam, for taking that detailed session. Thank you, Dr. Sharanya, second year MD student, for taking the case very beautifully. And some points were missing, but it's okay, it happens. Thank you for taking so much efforts. I thank Dr. Purushothaman sir and Dr. Laila madam for joining today and giving us the inputs about how our PG club is going. And Purushothaman sir has always been there for almost all our PG club presentations. Thank you, sir, for being there. Thank you, Dali madam, who is behind or deciding all the cases for us, our Vice President, IAB Kottayam. And thank you, Joseph Patani sir, for asking so many questions in between and making the session a very live one. Main thanks goes to our PG coordinator, Suresh Varkedam sir, and Shanavas sir, for always giving us opportunity to present our cases. Thanks to all the viewers who could participate today and made it a good success.